This is why they cause a failure of hematopoietic system. Then some of these cells will invade to the other organs. That means they come out from the bone marrow, then they can go through the spinal fluid cells, and they can invade into it. So what is the cause that causes leukemia? This unknown actually. Then probably some studies show that it's due to the oncogene or tumor suppressor gene alterations, and also because of host factors. That means the cell, whether it inherited the disease like hereditary immunodeficiency state, which is linked to sex-linked A-gamma globulinemia, or they have Down syndrome, which had tendency to increase to acute leukemia cases. And beside of this host factor, I think most of us know the environment factor, such as a nuclear weapon with ionizing radiations. The example can see through the Hiroshima and Nagasaki, where the ionizing radiation caused ALL, AML, and CML in most people exposed to this radiation. Some chemicals like benzene or the cytotoxin alkylating chemotherapy agents or virus, example Epstein-Barr virus, mostly we heard in can cause a leukemia or lymphoma cases. So the incidence for leukemia mostly involve adults compared to children, and the predominance is male compared to the females. So the table here show you various diseases of leukemia and lymphoma, and they are mainly involved in adult. So there, if you see the statistic from the median age at diagnosis, mostly they are elder people, adult patient, and only in ALL case here, maybe below 15 or 15 above, mostly we'll find ALL case. And there are 5 years survival, if you see here, also 20, like AML, 26% only alive through the 5 years. But for the CLL here and NHL, they are more higher people because they are slow growing disease. So today I will mainly concentrate in leukemia. We're not talking much about lymphoma. So in leukemia, frequently we'll see patient will come, we'll see an increase of white blood cell count, and they're complaining with fatigue or recurrent infection, and sometimes they have heavy bleedings. Because of this, because of why they presented of this type of clinical, because there's a two main concomitant event occur is because the function of blood is reduced, because most of the mature cell is reduced, so they're full of immature cell, and the immature cell cannot function well. This is why sometimes if you see through the blood smear, in this slide you can see the normal blood. Normal people will have a red cell, white cell, and platelets with a mature cell. But in blood cancer, you see most of the your full blood smear will see a lot of blood cell or cancer cell, and few of these is a red cell and platelet. In hematologic malignancy, mostly they are classified based on cell line. Cell line, that means either you are myeloid cell or lymphoid cell, which there are different cell of origin giving rise to the different type of leukemia. And at the same time, we also will classify whether it's onset based on progression, disease progression, whether it's acute or chronic. That means how fast the disease occur that happen. If acute in very short time, chronic maybe they take more than a long time to become a aggressive case disease. So just now the previous, the hematopoietic system. So now you can classify into two. It is myeloid and your lymphoid in your right hand side. So from the myeloid and lymphoid, they will divide and differentiate into different type of specific cell accordingly. So I think probably in your previous lecture, you already know how these cells differentiate into the specific cell or mature cell. So in between these two, for these two cell line, so if you see under this slide, in myeloid disorder, you can differentiate, and myeloid or lymphoid disorder, you differentiate into two types, either a chronic or acute leukemia. For myeloid, you have a chronic myeloid disorder and acute myeloid disorder. So in between these two, they have another divide in the subtype of leukemia. Same thing with lymphoid and disorder. They have a chronic lymphoid disorder and the other have acute lymphoid leukemia. All these will subdivide into different type of disease based on their clinical presentation and also sometimes with their clinical, the cytogenetic marker or molecular marker. So what is the cytogenetic in hematological malignancy? And I was told that probably you all also already go through the cytogenetic, probably have some information on this. So today I just refresh back. So it's the study of chromosomes. What we study is abnormal number or structure of chromosome. And it's become a critical aspect, important aspect in the workup of hematopoietic neoplasm. Because why? The hematological malignancy, mostly they have chromosomal abnormalities. That means we can detect the abnormalities through cytogenetic study. And the pattern of chromosome aberration, either is structure or numerical, can help us to predict treatment response and also clinical outcome and whether it's good or not good, and help us to do a risk stratification. Later, probably in the few slides, I will show you, share with you how this help us and how this can tell us whether the patient or person respond good to the treatment or not. And with the break, the gene located at the breakpoint of a certain recurrent abnormality also is important to help us to know the role of this gene in the tumor genesis and also help us to choose the target of treatment. Currently, there's certain leukemia have a target treatment, but must based on certain marker from cytogenetic or molecular to give to the patient. So this slide shows us to share with you there's many recurrent cytogenetic abnormalities that occur in leukemia. So this few type of leukemia that I show you here, that chronic myeloid leukemia (CML), acute myeloid leukemia (CML), and ALL and MDS. All they have different type of recurrent chromosome aberration in a particular patient, or some they are very unique because, for example, CML translocation 922 is a very unique to the CML. Although there's some of these some disease such as AML, AL also have 922. And the recurrent breakpoint of the cytogenetic abnormality, it could be involve a balanced translocation. It can be a deletion, duplication, a marker chromosome, or either they have a ploidy chromosome, either they have gains and loss of chromosome. So what is the importance of the cytogenetic in hematological malignancy? Because it can help us to diagnose and to do a prognosis and classification into whether it's good response or they have a very worse dismal overall survival, and also help us to risk stratification and selection of proper treatment or potential treatment advance in certain diseases. And also, they allow us to do a follow-up of the response or monitoring of treatment response to the disease. And so the few slides after this, I will show you how cytogenetic contribute to the diagnosis, and I use to the diagnosis and help us in certification and identification of their treatments. So next slide is so. Let's say you have a bone marrow slide, or you have a picture of the full blood count, full blood picture. At your left right hand side is full. You can see full of the blast. So blast is the one you have a very big nucleus with scanty plasm. So this is marrow smear from patient presented with pancytopenia with multilineage dysplasia. So the what clinical will report for us is like hypoplastic feature. Pancytopenia, that means maybe probably your cell count, all the cell line, 3 main cell line, white cell, red cell, and platelet all are reduced. So in this here, probably clinician will put a diagnosis and myelodysplastic syndrome. Then in certain cases of MDS, particularly in refractory anemia, this is one kind of clinical that were presented in MDS, are difficult to diagnose by morphology criteria alone. So sometimes they will ask for a cytogenetic test to see what type of marker that will present in MDS. So if you have this cytogenetic, that means alignment of all the chromosome into the group. Here you can see the presenter is a monosomy 7. That means it's a chrono acquired chromosome MLD, which normally have a poor prognosis or outcome for a patient who have acquired this abnormality. So that means the loss of chromosome 7. So this is one of the important that cytogenetic use in the diagnosis of the cases. There are a few others cases also have a similar thing, but today I just present one for you. So next is how cytogenetic help us to do a risk certification. Okay, before that, just share with you. Recently, this is a most recent WHO, I mean World Health Organization, a system for 2016 divide AML into several groups. So this is very common marker in the AML that found in AML. So the professional entity here described is that means the markers are still not yet clear is if they have enough evidence to the specific group yet, but they are still classified into AML. So when you are doing cytogenetic analysis, we will base on what type of the clinical that we find in this disease. Then we will classify into based on their presence of the cytogenetic marker. So maybe before we go to the cases, probably just go through what is acute myeloid leukemia. It's a heterogeneous group of disorder at the cytogenetic and molecular genetic level. And chromosomal abnormality are seen in about 50 to 60% of patients with newly diagnosed AML. This means that probably about 30% above, normally the cytogenetic is normal karyotype. But there are several specific recurrent chromosomes that specific described in AML like at translocation 821, 1517, and inversion 16, which have a specific and distinct subgroup of this type of AML, and mostly they are good in very good prognosis. So when we identify cytogenetic abnormality in AML, we can classify into either three main group. One is favorable, an intermediate, or worse group. So every specific of the marker can tell us whether the patient will respond good to the treatment or not. So like I said just now, 1517, 821, and inversion 16 is favorable, and adverse is mostly like just now what we saw. Previous one is a monosomy 7, loss of 7, deletion of 5q, or any abnormal of 3q. And intermediate risk group is other than these two groups. Normally will be loss of Y, trisomy 8, 11, trisomy 11, trisomy 13, and 21. From this, all these marker, through their marker also will estimate whether their overall survival, whether it's better than the other or not. So this slide show you again the 1517, 821, inversion 16 is a favorable survival compared to others. So another risk stratification we can do for myelodysplastic syndrome MDS, as the previous slide just now we show you. Just a little bit more. MDS are a group of heterogeneous clonal hematopoietic stem cell disorder, and the presence of dysplastic changes is one or more of the changes in one or more of the hematopoietic lineage, because they involve mainly all three cell lineage. That means red cell, white cell, and platelet all will be involved. So sometimes they were presented with pancytopenia, or they will do what we call aplastic anemia. So their classification also based on their clinical presentation into few other subtype, which we will not explain one by one because they have their a specific clinical outcome also. And this slide shows in each of the subgroup, the chromosome abnormality is present in a certain subgroup. But you can see here all the MDS, mostly they will have a deletion 5q. So when mostly when they are sending to us QRI MDS, or they put some like just some pancytopenia cases, they will ask us to look for deletion 5q. Why deletion 5q? Later, probably in the next slide, we will show you why deletion 5q. So in this slide, the study involved about 2,754 MDS. So from this study, they identified a few of the cytogenetic abnormality found in this MDS patient can be also divided into very good, intermediate, and poor or very poor. There are 5 groups they include. All of these, they are a good, their level of the response, they are based on the good reference in deletion 5q, mostly. So when you see the abnormality in single, that means they are solely present as a abnormality. If you see they have double or complex, that means they have other than the other chromosome present too. So their median survival for the deletion 5q here, which I put a dot circle here, is about 48 months compared to the other intermediate, poor, and very poor. So from here, very poor is normally is monosomy 7 or deletion 7. And a good one is a loss of Y and deletion 11q. So from this, just now we go through AML and MDS, you probably will notice that I always mention monosomy 7 is a poor prognosis. So for these two diseases, MDS and CML, if present of the monosomy 7 or deletion 7, they are considered a very poor prognosis for both cases. So another paper from the Japanese, Tasaka et al., they recruit about 131 MDS patients with only deletion 5q. Since we know the deletion 5q cytogenetic abnormality is good prognosis, and probably they will say, what is happened if this deletion 5q present together with other chromosome cytogenetic, whether it still be good prognosis or bad or worse. So from this survival curve, we can see the lower part of here, if the present with the chromosome 7, it becomes worse, although 5q is, deletion 5q is a good prognosis. And same thing when it present in the complex is also very worse prognosis. Other than complex and monosomy 7, well, although it's not significant showing that it's a good prognosis, but it's showing seeing that it's better than the deletion 5q. So at your left hand side, you can see the two examples of deletion 5q. The deletion 5q is based on a region that involved, but actually in whatever region that involved, they are category under the deletion 5q have previously been well defined as having relative good prognosis and MDS, and but very poor prognosis when it combined to other anomalies. So another risk stratification to the acute leukemia, lymphocytic leukemia, also is the same thing under WHO 2016 classification. They will divide into a subtype of ALL, and also be compared based on the marker detected in ALL. So here in your left-hand side is the ALL phenotype detected by flow cytometry, and it consists of a few types of chromosome aberration that is present in ALL. And from this marker, they will show, they will tell us how the prognosis is. So at the previous, just now the MDS slide we saw, we said complex or complex cytogenetic will be poor, and if you see the ALL, if you have hyperdiploid with more than 50, and the mid-prodigy abnormality, they have a very good prognosis actually in ALL. But other than this, if you have 922, translocation 922, although the incidence is only 3 to 4%, when you have this cytogeneity in the ALL, it's very poor prognosis compared to the other prodigy group. So this is example from a patient with a hyperdiploid prodigy. The paratype with the number model is 54. If you can notice here, most of these cytogenetic involve a numerical, no structural. So the high hyperdiploidic, which is more than 50 chromosomes, the incidence is about 25%, mostly in pediatric cases. When the pediatric cases, I mean children have this more than 50 chromosomes with hyperdiploidic, mostly involve the numerical, their prognosis is very good. I mean their outcome is very good. And in this hyperdiploidy also, the cytogenetic, they find out there is certain specific of the chromosome must be there. which is have an extra chromosome 4, number 10 here, and we have 10 trisomy, and 17. They are predicted is a good outcome. So normally when we have hyperdiploidy with the children or pediatric cases, then we look for the 4, 10, and 7 chromosome. So if we have this, so the prognosis probably will predict it's a good prognosis for this patient. So how about these cases? These cases is near haploid ALL. Okay, we also at the same time probably you maybe been told that cytogenetic in leukemia sometimes they not divide very good. They do not have a very good quality of chromosome. So sometimes we have this type of the presenting here, this type of karyotype. Probably you will think probably this is not enough a cytogenetic or karyotype chromosome. Maybe this is poor karyotype, because normally people will think about we have a 46 chromosome, so you must have complete chromosome. But for AL cases, if we have this type of chromosome, this type of karyotype, probably you need to do a few more spread of metacells to see whether they have a similar karyotype or not. So if they have similar more than 2 or 3 types, that means it's probably is a clonal abnormality. So this is a real karyotype for this patient. So this is near haploid ALL. Probably they reach about 25 for the model chromosome. Also involved in here in the picture here in the slide here is involved trisomy and trisomy 14 and trisomy 21. So the hypodiploidy with 44 or 45 chromosome has an intermediate prognosis, and whatever hypodiploidy less than 44, it seems a very poor outcome for the case of ALL. So another slide, I just we go through risk stratification for multiple myeloma. Is again just a brief view. Is a plasma cell neoplasm resulting from proliferation of immunosecretory plasma cells. It occurs primarily in middle-aged to elderly patients and affects. This one because I take from the conclusion is so their study involve African American more often than whites. So probably there is some ethnicity involved in this multiple myeloma. At diagnosis, about 15 to 30 patients will have asymptomatic. Asymptomatic, that means probably you don't have any clinical feature of the sickness or disease until you come to the laboratory to have your full blood count, full blood picture, then only you see there is abnormality in your blood smear. So sometimes they will have a symptom include weakness, fatigue, then you have bone pain. Normally multiple myeloma will cause a bone pain, anemia, and etc. So what is the impact of genomic, that means cytogenetic aberration in multiple myeloma? Cytogenetics are a primary risk factor in multiple myeloma cases. Why? You can see that if you have there's a good risk cytogenetic include hyperdiploidy with 48 and 74 chromosome. So the same thing also happen. Just now we're talking about the diploidy abnormality. If you have hyperdiploidy in children ALL, it's good. Same thing with multiple myeloma, but normally they will involve the odd number, such as 3, 5, 7, 9, 11, 15, 19, and 21. If you have this number with a hyperdiploidy, probably you can predict a good response for this patient. So another important in cytogenetic, but this is mainly we have to test on the little bit higher resolution than cytogenetic, which is probably involved in fish analysis. But today we will not talk much about this for this presentation. But I can share with you the deletion 17p normally we'll look for deletion 17p. Why? Because they have a tumor suppressor gene in the P is the short arm of the chromosome. So when we have this 17p deletion detected, it will show the poor impact overall on survival of this multiple myeloma. Same thing with the 14 translocation 4 to 14 and on deletion 13q. All this will show a very poor prognosis, poor overall survival for multiple myeloma. Another disease, chronic lymphocytic leukemia. This is a B-cell neoplasm. It's the most frequent adult leukemia in the middle-aged to elderly patient. Hardly and no seen in children, mainly comprising up to 30% of adult leukemia, and always also is a male predominance than female. Genomic evaluation in the CLL are important independent predictor of disease progression and survival, and this finding have implication for the design of risk-adapted treatment strategy. So, same thing with the multiple myeloma. In this graph, when we do the cytogenetic CLL, probably we need to see a few of these chromosome abnormality, which involve chromosome 70, chromosome 11, chromosome 12, and chromosome 13. So here, DEL is deletion. Its deletion involves 17p. Again, same thing with multiple myeloma. Will have a very poor prognosis, respond poor to the treatment compared to the deletions 13q. Even though even with deletions 11q also very poor prognosis compared to deletions 13q. So this multiple myeloma and CLL normally is a slow growing cell, and sometimes we'll hardly see the cell grow very well in cytogenetic. And however, we mainly normally will detect looking to the deletion 17p because they have a specific in CLL they have specific treatment for that. If you have deletion 17p, probably doctor will use more advanced treatment. For multiple myeloma is a prognosis that means tell us that probably patient not respond good. So in next is a few more slides to end this section. I will share with you how this cytogenetic important in follow-up of clinical causes. So here I presented is a chronic myeloid leukemia. It's one of the, I think, easier way for us to understand the importance of the cytogenetic in the follow-up of clinical causes. CML is a myeloproliferative neoplasm characterized by unrestrained expansion of pluripotent hematopoietic stem cell, and normally is a marker. The genetic translocation 922, chromosome 9 and 22, which in your, if you see under the scope or you do karyotyping, you can see the derivative chromosome 9 with elongation of Q is a long arm of chromosome, and at the same time we'll also see the very short chromosome 20, the loss of the Q chromosome, which we call this is a Philadelphia chromosome. Translocation 922 is present in about 90% of CML cases and has been demonstrated in myeloid, electroid, and megakaryotic cell lines. So what is the treatment? This is the treatment for CML frontline therapy. They have 4 tyrosine kinase inhibitor. Tyrosine kinase inhibitor is a targeted treatment for CML. So they have first generation is imatinib, followed by they have developed another next generation, second generation, nilotinib and dasatinib, and recently they have ponatinib. All these various type of tyrosine kinase are developed to treat patients with different. They are 922, but probably they will have acquire other chromosome other than 922, or they have mutation that probably need more advanced tyrosine kinase. This is why the various type of the therapy is developed. In CML, they can progress into mainly 3 phases: chronic phase, and then to accelerated phase or blast crisis. Is often associated with secondary chromosomal aberration. So what is the secondary chromosome aberration? Is other than 922, what other chromosome will come up, will appear after 922 or along with 922? There is a secondary chromosome aberration. So in this case, then cytogenetics can tell us whether the patient is under which stage of the phases. So in this slide, you can see under the full picture, probably is full of the blast cell, some of the mature cell, because this is chronic cases. So chronic cases, you will mix with the highly blast cell, maybe immature cell. Sometimes it's intermediate mature and some is a mature cell. So here I show you that why this time we discuss about certain of the BCR, certain of the marker is mainly specific to the disease. But however, when you see this 922 and BCR-ABL, it always present in CML, and some cases about 30% is in ALL, and very rare in AML, about 1%. And all this prognosis is very poor either in children or adults, especially in ALL. But some in CML, sometimes patient will show good response, probably because of the type. Just now, if you remember how we classify them to chronic and acute. So normally acute will have a poor prognosis compared to the CML, to the response to the treatment. And coronal abnormality in addition to 922 also mostly happen in the cases with ALL. That means they have a secondary chromosome abnormality. So outcome have their outcome, whether it's as a sole, that means it has an individual 922 and the other secondary chromosomal abnormality is almost similar with to the patient with base positive with a shorter duration of remission, and they have an inferior overall survival. So just to show you how this pH occur, that means they have this is a reciprocal translocation between 922. At your far right hand side, you will develop chain chromosome 22 to the shorter chromosome, and it becomes what we call now is Philadelphia chromosome, which is discovered by Nobel and Hungerford in 1960. So before I end my slide, this is a last case I share with you. There's a 31-year-old female. This case we presented on a very long time ago, 2008, in this paper, with splenomegaly and was diagnosed with CML. Normally, leukemia chronic cases, they have a very enlarged spleen, and the diagnosis of the case is 46XS 922, only have 922 abnormality. Then patient start the treatment with imatinib mesylate and there's tyrosine kinase. Then after this, patient develop a myeloid blast crisis. That means they have transformed to the blast stage. Still remember, just now we said CML have got 3 phases. So this transfer to myeloid blast crisis. So they have additional chromosome abnormality, which is transcription 321 in addition to 922. After this, after treatment, patient also going through the his SCT is a hematopoietic stem cell transplantation. That means patient is transplanted. However, patient not respond good and he relapsed. That means the disease come back again. Then we also do a FISH test for this to see what is the abnormality other than this 922. So this is her previous. Actually, I don't have her previous picture, but this is for example how to show you a 922 translocation. And this is her picture, karyotype after the myeloid blast crisis occur, which you can see other than 922, which involve chromosome 3 and 21. 21 become longer. You see the chromosome 7 shorter, and loss of chromosome 17 and 18. And also you see this 22 here. You see there's two identical structure. This is what we call a isodicentric, or that means two pH positive is joined together. So this is if you see under the FISH analysis, you will see amplification or fusion that happen. Probably you don't see that. I can show you the FISH later, the picture. So based on this cytogenetic appearance, that means it shows that there is a emergence of additional cytogenetic abnormality was observed, which indicate that the patient is refractory to the treatment. That means they have poor treatment response. So this is a FISH result that we do. Probably later, if we have chances again to meet, then we can share how we do the FISH analysis. So just share with you. For this is from your B figure is the karyotype that we have in metaphase. You see the two fusion yellow. Just now where I show you the structure, they have joined together, and the C label is interface, another FISH observation to the interface. You see the fusion is the marker for BCR-ABL formation. That means, so here you can see 1, 2, 3, 4 or 5 fusion. That means they have increase of Philadelphia chromosome. Although the cytogenetic is important in hematological malignancy, and we see how it helps us to do a classification, but we also have a counter few limitation of this cytogenetic because it requires a high rate of dividing cells. If your leukemia not divide, you're not able to see any of the marker of this. So some of leukemia disease cells are not proliferating during culture. So the cytogenetic sometimes result may not representative for malignant clone. It means that sometimes if you see normal karyotype, it not mean the patients don't have leukemia. If the patient have clinical presented a disease, but normal karyotype, it doesn't mean that the patient is no have that disease. Then the chromosome abnormality in leukemia could be cryptic under light microscope. Probably the disease is very small that we're not able to observe under light microscope. So probably it appear normal. So by this, then we need the other technique to help us to confirm, to find any genomic aberration to the disease. So today, my sharing with you, we have covered, we have known that indication for cytogenetic probably when cases is unknown cause of pancytopenia or probably you have fever, then all suspected AML, ALL, or MDS in diagnosis, or probably doctor suspected of CLL and multiple myeloma need a risk stratification, and to see whether treatment response, probably they will send to us for this study. So in this presentation also, we also understand that cytogenetic abnormality define the particular genetic subtype of leukemia, and also it helps us in to diagnose and staging, also as well as prognostic treatment and treatment response evaluation of the disease. Cytogenetic aberration incorporate with other findings as well as morphology, immunophenotyping, and clinical feature in the classification of leukemia and lymphoma. It means that it's not only based on cytogenetic aberration to classify, we need other technique to help us to precisely divide this cell into a few categories to see whether the disease is respond good to the treatment or not. Before I last end my presentation, this is what we do in Hospital Ampang, and mostly in cytogenetic lab. Probably in next time, maybe in next year or a few years, that during your course you have to attach to the laboratory, or maybe after you come to the work. This is most of the review all these technique that probably involved in this cytogenetic. So you have to know the cell culture, what type of cell culture that you need, and calculating of cell to do a cell culture. Then finally go how to get the cell suspension. Later you have to modify certain temperature or aging the slide before you go staining. So staining normally will involve G banding. That means you can see a layer of different color. It's only two color normally in microscope, black and white, to produce a band to you. So by this band, it tell you what chromosome classify into group. So probably if you have time, you can come to the cytogenetic lab, or we can discuss again how we identify this G band for the chromosome. And later, when you have all complete with G band, you will go through a screening and capturing for the image analysis. So it's either will be automation, or you have to do manually capture, or you have to learn of this based on the what type of the machine equipment cater in the laboratory. Finally, from this, we have to do a karyotyping. From this karyotyping, then you have you can identify the marker chromosome. So I end this talk, this slide for this, and thank you for your attention. So I'm happy to have your question. If I can, I will try to answer on my best. Thank you very much.
Thank you for the excellent presentation, Ms. Pan. So I think all of us here already got a brief overview about the importance of cytogenetic testing, especially in the diagnosis and prognosis of hematological malignancies, as well as in the treatment management. So before I open a Q&A session to all the participants, I would like to ask a question to Ms. Pan. So with the advances in technology, there are several methods have been introduced, such as molecular techniques, such as PCR, sequencing, and so on. So in your opinion, can cytogenetics be replaced by those techniques? Because we know that molecular approaches such as PCR and sequencing can give a rapid result compared to cytogenetics. So what is your opinion? Can we replace the cytogenetic testing?
Okay. A lot of people, when there's a next generation come out sequencing in the panel, people say, "Oh, this will be because it will become a precisely as you say, fast that probably can replace cytogenetic. But when I go through a lot of the study, reading and other from a cytogeneticist, probably I think is few other things we need to consider. If you're able to have money, when we talk about the high technique, it will involve money. So when involve money, that means you need to have involve money. That means you what I mean is you want to diagnose certain diagnosis. For example, if you have a CML, because CML basically, even though the BCR able can detect, eventually the doctor also need to define whether there is a pH marker or not. Okay, in CML, because certain cases, let's say in cytogenetics, certain cases in BCR able, I'm talking about PCR, if your design of primer is not in between the breakpoint, you will not detect the marker. We have a few cases is like that. Because we want to do fast, so we go to do a molecular, but molecular is negative. So, but the clinical presentation is look like CML. So they turn to fish analysis. So fish analysis help us to define this is pH positive. But another incident, when sometimes they say the suspect is a BCR able, they run PCR, also negative. Then they want us to look for cytogenetic. Normally we will see pH, short pH, but actually no, there is a normal. So there is some cryptic changes in the cytogenetic. So based on this, I feel this should be a complementary, not a replacement each other. Because look like multiple myeloma, the PCR, normally people will not do PCR first because they have no specific marker. You have to go back to cytogenetic. And even for CLL, you have to go back cytogenetic. But unless you have, you need to find another very cryptic abnormality, then you have to use other techniques. So I feel from my what we have here, normally what we see is a complementary test that in various technology can help you to define and also to choose the technique is also based on the treatment that they currently we have. And this is what I understand.
Okay, thank you, Ms. Pan. So I think we do agree that cytogenetics remain the gold standard testing for hematological malignancies, but other molecular techniques can be act as a complementary or to confirm the finding, right?
Yes.
Yeah.
Yes.
So I will open for Q&A session. So anyone? So I would like, before you ask for a question, I would like you to introduce yourself and proceed with the question.
We are waiting for your answer. Probably I will not say encourage, but maybe share with you that if you have a cytogenetic, it's very technical. It's not really can replace by fully automated machine. So if you have that skill, also probably will help you a lot in your work later.
So anyone?
Is the presentation is too light or too heavy, or probably not really understand much?
I think they're quite shy to ask you a question. normally in the normal lecture, there's a lot of questions.
Tak apa, boleh
So if
boleh tanya.
if you're comfortable with the bahasa, then you can proceed with the bahasa, right? It's fine.
Ya.
Yeah. Don't be shy. It's not easy for us to have
Soalan yang
Miss Panchili who has vast experience in cytogenetics. So maybe in the future, maybe some of you might work together with Miss Pan. Who knows?
come to the government
Yeah.
KKM.
Or maybe anyone can ask. You also can ask about the experience. Maybe Miss Pan can share with you experience on
They
how
are
to
now
become a
in
cytogeneticist.
third year, is it? They are third year, I think. They are now
Yeah,
in
now semester 5, I think third year. Anyone? Pak Izzuddin, Pak Is, ada soalan?
Ya, doktor. Actually, it's not like a question, but I just curious.
apa-apa saja.
Saya macam curious dalam untuk presentation tadi, mostly kita belajar based on the salah satu faktor yang kita nak buat untuk diagnosis in cytogenetic, tapi apa yang saya faham mostly cytogenetic lab untuk ke hospital macam tak banyak. So maksudnya sampel tu kita hantar kat reference lab macam tu ke kita hantar ke IMR untuk baru dapat ni. Sebab saya tahu macam cytogenetic ni mostly macam expensive, dia laborious. So mostly hospital dia tak ada macam tiap hospital tak adalah specific cytogenetic lab. So saya macam kalau nak untuk diagnose hematology disease, adakah sampel-sampel ni kena hantar dekat macam reference lab macam yang ada cytogenetic untuk confirm ke, atau kita just macam kadang-kadang sempiang je dah cukup untuk diagnose benda ni? Itu je saya.
Okay, thank you Faizuddin. Actually macam ni, in KKM kita hanya ada beberapa hospital untuk sementara ini yang buat cytogenetic. Satu tu macam Faizuddin cakap di IMR, kita juga ada di HKL, sekarang pun ada di Penang dan Ampang salah satu lah. Dan mostly private pun ada. I think hopefully from your course later you all come out can work in cytogenetic lab, because kita memang tak cukup ramai orang. So kalau you all ada yang berminat, bolehlah nanti join di cytogenetic lab. So dia tak semestinya pergi, dia kena tengok di mana. Kalau mostly kalau ada duit dia orang akan pergi ke private, tapi selalunya kalau MOH, KKM, beberapa hospital yang saya sebut tadi, itulah yang kita buat sekarang sementara waktu. So hopefully after end of your section ke, nanti bolehlah you all bekerja di cytogenetic lab. Kita perlukan orang yang genetik pegawai sains.
Saya setuju dengan Miss Pan, because cytogeneticists kat Malaysia ni tak ramai, and this is very require a high skill individuals. So normally you gain experience by years, right, Miss Pan? So
yes.
yeah, you cannot be a competent cytogeneticist in one day or even a year. So by doing it every day, you might gain the skills to become a competent cytogeneticist.
Cytogenetic bukan saja melibatkan disease like malignancies, but also in constitutional. Sometimes ada masalah macam apa tu curie, apa tu sama apa tu abortion, atau nak identify sex determination, also need a cytogenetic for the culture. So today kita talk mostly penyakit, tapi dia ada juga melibatkan buat cell culture kepada penyakit macam misalnya you all nampak Down syndrome. Itu adalah salah satu macam mana kita nak confirm, kita akan buat cytogenetic. Dan kita akan nampak kalau Down syndrome adalah trisomy 21. So based on trisomy 21, only we can confirm this is a Down syndrome cases. Itu salah satu contoh dia lah.
So, any other question? We have Dr. Emida here. So, Dr. Emida, do you have any question to ask to our guest speaker? So, Dr. Emida is lecturer for hematology. So, maybe this topic is somewhat relevant to her field.
Can you correct me if I'm wrong?
Thank you,
Hi,
Dr.
Doctor.
Fazlin.
Yeah.
Hi, Miss Pan.
Miss Pan, yeah.
I would like to ask, apart
Yeah.
from for hematological malignancies, in what other cases can cytogenetic be used?
Mostly my experience deal with bone marrow and mostly in hematology and malignancy. So other than constitutional cases, also we can do a cytogenetic, and probably on other cancer cell, not a hematology cell. The cell that can divide into metaphase can do a cytogenetic analysis. So it's not even involved in marrow and blood as well. You can involve in lymph nodes, cells, and other prenatal cases cells. So they can involve as long as the cell can divide, can be cultured, then to obtain the metaphase to see under the microscope.
So maybe one or two more questions.
Yeah.
Maybe shall I just ask anything that be bothering you? So Miss Pan, so what I'm aware is that in Malaysia there is no certified cytogeneticist at the moment, right? So I mean,
certified in
yeah, I mean in terms of
overseas.
professional certification for the cytogenetics.
Normally they will not apply, or you can participate in overseas degree and this overseas course. But in Malaysia we don't have that yet. Probably maybe you can think about this, and we can have the certificate later from this. Yeah, I think there's a lot of things that we can do from here now, because there's not many of us, and I think this is a new area for Malaysia to develop, to come out, to be well organized on this.
Or any last question?
Nak tanya pasal kalau macam kalau treatment macam yang tadi kan, macam untuk presentation tadi, mostly kebanyakan daripada AMS, CML tu semua, dia macam kaitan dengan chromosome defect. So kalau macam tu, kalau untuk kita treat dia, kita nak treat macam mana? Kan kita treat just like by symptom saja.
Chromosome defect untuk penyakit hematologi ke atau untuk penyakit lain? Yang Faizuddin cakap tu?
Yang ni mungkin kita yang hematologi dululah.
Hematologi selalunya dia bukan based on marker, bukan semua, tapi macam tadi yang kita present, kalau masih ingat lagi CML ada 922, semestinya kita akan ambil what we call tyrosine kinase inhibitor. Itu memang marker ubat untuk CML. Tapi untuk certain AML, dia punya treatment adalah standard. Kalau bukan based on marker. Tetapi marker diperlukan untuk kita kenal pasti because dia akan memberikan kita gambaran bahawa pesakit itu mungkin akan mempunyai respon yang bagus atau tidak kepada ubat, supaya doktor dia boleh buat perancangan mungkin perawatan yang lebih teliti untuk pesakit. Contohnya nak prepare dia pergi transplant. Selalunya kalau boleh dia orang akan bagi transplant. Although sometimes walaupun transplant tu pun mempunyai risk juga untuk mungkin dalam proses tu patient tak akan survive juga. Tapi itu adalah salah satu perawatan yang akan bagi kepada pesakit lah.
Saya rasa apa Pak Budin nak maksudkan tu, adakah treatment ni boleh membuatkan kromosom abnormality tu hilang lepas treatment? Contohnya 922 tu lepas treatment dah tak ada 922.
Yang hilang tu kita panggil kalau masa kita bagi treatment, selepas itu kalau kita nampak cytogenetic normal bersama dengan clinical presentation dia, patient nampak macam sihat, blood count normal, that mean patient respond good. Dia bukan hilangkan kromosom itu. Bermaksud clone abnormal tu dah kita panggil mati lah, dia tak growth, dia tak tumbuh semula. Itu yang kita panggil. Tapi kita bukan hilangkan kromosom itu apabila kita nampak cytogenetic itu normal. Mungkin dia bermaksud klon yang sihat ada, tapi yang tak sihat tu semakin lama semakin dia sebab dia respon ke blood treatment, kita panggil respon treatment, that means the cell will die eventually lah. But anyway, sometimes this leukemia pun degil juga. Dia respon sekejap saja, selalu kita nampak macam tak ada marker, tiba-tiba dia tumbuh semula pun ada.
Okay, Faizuddin.
Okay, Doktor. Thank you, Miss.
Okay.
So, if there's no more questions, so
I think nampak Faizuddin begitu minat tentang cyto. Maybe you can train her very well. Train him later.
so even in the lecture, he always ask questions.
Very good. Actually, asking is good. Learning from that. Don't be so shy.
Yeah.
Okay.
So,
Anyway, before we end, I really thank you for all the participants, and I really thank you for the opportunity given to me to meet all of you here, 57 of you. So hopefully we can meet again, Dr. Fazli.
okay, so on behalf of Center of MLT UiTM, again, I would like to thank you, Ms. Pan Chin Lee, for taking time from your busy schedule. I know you are busy. And I hope we can keep in touch for future collaboration, maybe in the form of webinar or also even for future training purposes. Okay. So thank you again.
Okay. So I
All
think
the
we
best.
say goodbye now.
Okay.
Yeah,
Bye.
Aliana. Yeah, bye. Bye everyone and take care.
So for all the students, don't forget to record your attendance in the future. And also I would like to ask all participants to please fill in the feedback form that I shared in the chat room. Okay. Thank you.
Thank you. Thank you, Doctor.
Thank you, Miss, and thank you, Doctor.
Thank you, Doctor. Thank you, Ms. Fan.
Thank you, Miss. Thank you, Doctor.
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 Thank you, Miss. Thank you, Doctor.